everyone. My name is Janet Rossant, and I'm President and Scientific Director of the Gairdner Foundation. The Gairdner Foundation, based in Toronto, Canada, was established in 1957 with the main goal of recognizing and rewarding international excellence in fundamental research that impacts human health. Annually, 7 prestigious Gairdner Awards are given, and over the last 60 years, we've given 402 scientists from 40 countries. 96 of those have gone on to win the Nobel Prize. But part of the Gairdner's core mandate is, beyond celebrating excellence, is to really inspire the next generation of researchers through our Pan-Canadian outreach program. And this Global Perspectives panel event that we're doing today is the first in our 2022 series of such events. In the early days of COVID-19, the Gairdner Foundation switched everything virtual, and we quickly realized that we had an opportunity and perhaps an obligation to help provide Canadians with information they could use to understand the global pandemic and its impact on everyday life. We launched the Global Perspectives panel series in 2020, and very successfully, and we're very excited to be here offering another round for 2022 starting today. And this particular panel follows closely on the launch of the Lancet series, Optimizing Child and Adolescent Health and Development, which was released on April the 28th. And this 2-day event that we're launching here is really following up on that and looking at the challenges, interventions, and opportunities for school age and adolescent well-being. Today and tomorrow, you're going to hear from world-renowned global health experts on topics ranging from the impact of the COVID-19 pandemic in South Asia, to adolescent health in humanitarian settings, to youth reintegration after trauma, to climate change and youth well-being. This is about the next generation. This is about the future of our planet. What problems are children facing today? And what is in place to help mitigate those barriers and problems? What does the future hold? We obviously need to all work together to ensure that our future generations are set up for success. And the discussions that are going to come out of today's series, I think, are a step along that path. We would like to thank our presenting sponsor, TELUS Health, and our partners in this Global Perspectives panel, the International Development Research Centre, IDRC, and the Hospital for Sick Children's Centre for Global Child Health. And now I'm going to hand things over to Dominique Charon, who is Vice President, Programs and Partnerships for IDRC. Dominique.
Thanks very much, Janet. And it's really a delight to be here with you as part of this really important discussion today and to be together with the Gairdner Foundation for the discussion. I'm speaking to you today from Ottawa, Canada, which is on the unceded traditional territory of the Algonquin Anishinaabe people who've lived here for millennia. And I honor them and all First Nations, Inuit, and Métis people and their struggles and their important contributions to the present and future of the land that is Canada. For those of you who don't know us, as a key part of Canada's foreign affairs and development efforts, IDRC works alongside researchers in low and middle income countries to conduct research to address key development challenges. In partnership with them, IDRC shares knowledge globally and mobilizes alliances for a more sustainable and inclusive world. We really are delighted to be Gairdner's partner again this year. In the last few years, we've worked together to shed light on key topics in global health, most recently child health, as Janet mentioned, and global health and sustainable development through the pandemic lens. We continue today with this conversation among leading thinkers on the health of school-age and adolescent kids, age groups whose health has not had the attention often that has been shed on the health of newborns and younger children, but whose lives have been significantly impacted by the direct and indirect effects of the pandemic. And we know some of these health effects are already known, such as a significant uptick in mental health issues diagnosed where these services are available, and many other unknown impacts over the life course of kids going forward. At IDRC, global health is one of 5 programming priorities, and kids and adolescents remain part of our focus, particularly adolescent girls. We have 2 health systems strengthening goals in our strategy to 2030. One is around improved maternal, child health, sexual, reproductive health, and rights for women and girls. and second, improve prevention, preparedness, and response to diseases of epidemic and pandemic significance. I'm quite honored that some of IDRC's research partners will present their work today. IDRC's support of African-Canadian implementation research partnerships on adolescent and reproductive health and maternal health led to significant impacts, such as doubling of reproductive health and family planning visits by young men and women in Mozambique, and improved diagnosis and treatment of perinatal depression among adolescent women in Nigeria, resulting in a 30% better recovery rate among the intervention group. So you can learn more about this and other research on IDRC's website. I encourage you to visit us. Now, the next session will be chaired by our distinguished colleague, Dr. Zulfiqar Bhutta. And I'll just take a moment to introduce him because he is the 2022 John Dirks Canada Gairdner Global Health Award Laureate, and we can't miss the opportunity on this day of all days to celebrate that. Many of you will know Dr. Bhutta is the founding director of the Center of Excellence in Women and Child Health and Institute for Global Health and Development at the Aatekah University. And he's the co-director of SickKids Center for Global Child Health and professor at the Dalla Lana School of Public Health at the University of Toronto, among many other roles. The Gairdner Foundation recognized him for the development and evaluation of evidence-based interventions in child and maternal health for marginalized populations, focusing on those outcomes in the first crucial 1,000 days that we recognize as so important now, thanks to his work and the work of many others. We're really pleased at IDRC to have been a part of supporting Dr. Bhutta's work over many years. And with warm congratulations and thanks for agreeing to lead the next session. And thanks also to the Gairdner Foundation for co-organizing this with SickKids. The floor is yours.
Well, good morning, good afternoon, good evening, ladies and gentlemen, from wherever you are connected. And thank you ever so much, Dominique and Janet, for those kind words in introducing this fantastic seminar. I'd like to take the opportunity before we start of particularly thanking IDRC because, as Dr. Asant mentioned, we have just launched an extraordinary, powerful Lancet series on looking at child and adolescent health across the life course. And a major supporter in that effort was IDRC in helping us develop the evidence base around some of those actions. As the launching pad of this seminar, today's first session is devoted to looking at the landscape analysis of our field. And we are particularly grateful for three stellar presenters representing both the leadership as it currently exists and the emerging leadership in the field. Just as a point of information for the audience, while the limitation of time precludes any live questions and answers, you are free and welcome to put your questions in chat with your identifiers, and we'll try and get those answers to you after the seminar. So let me start without further ado by introducing our first speaker, who's none other than Professor David Ross, who is the extraordinary professor in epidemiology and public health at the Institute for Life Course Health Research in Stellenbosch University in South Africa. David trained in Oxford and had a long distinguished career spanning over 3 decades at London School of Hygiene and Tropical Medicine, a big chunk of that spent in Africa. But notably, he led the seminal work at the World Health Organization between 2015 and 20 on developing the first global guidance in relation to adolescent health. And David will talk to us today about the state of global adolescent health and well-being. The floor is yours, David.
Hello, everybody. I'm very pleased to be with you today and to talk, give an introductory talk on global adolescent health and well-being. Because there's quite a lot to get through, I'm going to start by just making sure that the main message is there in your minds. and that's that adolescent health and well-being merits investment, and in fact merits considerably more investment than is currently being given to it. And that's for three main reasons: that adolescents are a large group with a substantial and increasing proportion of the global burden of disease. Secondly, because of the triple dividend, that interventions given in adolescence can reduce both mortality and morbidity during adolescence, but also the future adult burden of disease and injury, and also the burden into the next generation. And thirdly, because there's increasing evidence that interventions in this age group can work and provide an excellent return on investment, and that we increasingly know what to do and how to do it. So turning to that they're a large group with a substantial and increasing proportion of the burden of disease. This is the classical population pyramid that still applies for low and middle income countries. This is the pyramid for Africa as a whole. However, in many high income countries, there are more adolescents, 10 to 19-year-olds, than there are children who are aged in the first decade of life. This is the population pyramid for Germany. And this is because of changes in fertility relative to mortality. It's not true of all high-income countries. This is the United Kingdom. And you can see that there's slightly more children in the first decade than in the second. And this is a changing picture over time. These are the data for Switzerland. 2014, there were slightly more adolescents, so children in the second decade of life, than in the first decade. By 2020, there was slightly more in the first decade of life. The picture of mortality has been changing rapidly over the last decades. And these data, which are now a little bit old, but the pictures are fairly similar, from low and middle income countries, show that the mortality rates in 1 to 4-year-olds in low and middle income countries were still quite a lot higher than the mortality rates in 15 to 19-year-olds. However, if we look at high income countries, you can see that mortality rates, particularly in males, in 15 to 19-year-olds, were already considerably higher than they were in 1 to 4-year-olds, and even higher in 20 to 24-year-olds. If we look at trends, you can see that mortality rates are higher in older than younger adolescents, as we just saw, and that picture has not changed over the last couple of decades. And also that they're higher in males, considerably higher in males than in females. And the good news is that there have been declines, as you can see, in adolescent mortality rates, especially in the older adolescents. But the bad news is that these declines have not been as large as the declines for infants and young children. In terms of the leading causes of adolescent death, here you can see these are in younger adolescents, 10 to 14-year-olds on the left, and 15 to 19-year-olds, so older adolescents on the right. It's a mixture of infectious and parasitic diseases and violence and injury, with road injury in particular being extremely important, and with self-harm becoming very important in the 15 to 19-year-olds. In terms of the trends, here are the global trends in years of life lost due to disability. So if you like, morbidity related trends. And you can see that the years of life lost due to disability rates are higher in older than in younger adolescents, and in females than males. So the opposite gender difference than for mortality. But the bad news is that there's been virtually no change in the rates over these past 2 decades. In terms of the leading causes, the great majority of the causes of years of life lost due to years of healthy life lost due to disability during adolescence are due to non-communicable diseases. But we must remember, of course, that adolescents are not a homogeneous group, that there are groups of adolescents who are particularly vulnerable, and these include orphans, the disabled, and others that you can see on this list. And all of this, I just want to point out that the world is in transition, and that many policymakers are living with an outdated perspective on the world. You know, for example, many policymakers in high-income countries still think that young children, that's 1 to 4-year-olds, have higher mortality rates than 15 to 19-year-olds. Clearly, infants have much higher mortality rates, but young children currently have lower rates. And the health problems of adolescents and young people have long been neglected. And I think this is for 2 main reasons. Firstly, they're not in powerful positions yet themselves, and so their voices are not widely heard. And secondly, because they're not cuddly little babies whom everybody wants to help and to support. But clearly the importance of adolescent health and well-being and of interventions to promote health and well-being is much more than prevention of immediate death and illness. And the recently published, a couple of years ago, Adolescent Wellbeing Definition and Conceptual Framework of the UN Technical Working Group on Adolescent Health and Wellbeing shows the importance of good health and optimum nutrition is obviously enormous within adolescents' lives and for their well-being. But other domains are also very important. So connectedness, positive values and contribution to society, safety and a supportive environment, learning, competence, education, skills and employability, and agency and resilience. Turning to the second major reason why adolescents and their well-being and health deserve increased investment is the triple dividend. So that interventions in adolescence can improve the survival, the health, and the well-being of the adolescent during their adolescence. But also they contribute to the future adult survival, health, and well-being. And because of many adolescents will become parents in their adulthood, the survival, health, and well-being in the next generation. Adolescents, of course, do need support from adults, but they are also a force for development, or for unrest. And we've seen this very much so related to the climate crisis and the campaigns to prevent that. The third reason is that there's increasing evidence that interventions in this age group can work and can provide an excellent return on investment. And this is demonstrated in the Global Accelerated Action for the Health of Adolescents, the global AHA country implementation guidance that came out now about 5 years ago. It's currently being updated and there'll be a new version coming out within the next year or so, led by WHO, but it's a document of all of the UNH6 and others, including UNESCO. So why should we invest in adolescent health and well-being? Well, I think that there are several reasons. The first key reason is the human rights imperative. Adolescents have a right to health and well-being and interventions to improve that, and yet they have received less money than any other age group. Secondly, the demographic and epidemiological transition, and I've shown you a little bit of that earlier on. And thirdly, the social imperative, so reduced dependency, increased contribution to society that this can bring, this investment can bring. And a fourth reason that was very well demonstrated by work that was published in The Lancet in 2017 by Peter Sheehan and colleagues, showing that in terms of the pure economics of investing in adolescent health and well-being, there's an excellent benefit to cost ratio, so that for many if you choose your interventions well, and the global AHA should help with that, doing that, for many interventions, there's a return on investment that is at least $5 back for every dollar that you invest. And for some interventions, up to $12. And then, right back in, yeah. And the returns on investment were greater in low-income countries than in lower middle-income countries than in upper middle-income countries. So there's a potential for this in this age group for improving equity. In order to do this, it's really important that the adolescent as a whole and their entire well-being need to be put center stage, clearly supported by family and peers, schools and communities, the local environment and the wider society, but the adolescent as a whole person, not just as a particular siloed part of that person, such as their health or their education, need to be put at the center of these interventions. And that this will require realistic investment. Currently, the investment is far too low. It needs to be much more realistic. It will require multi-sectoral programming in order to achieve adolescent well-being across all these domains. And it will need meaningful engagement of adolescents. And there's a global consensus statement that has been signed by many different organizations on what does that mean. So thank you all very much. And I very much look forward to the discussions that will happen over these 2 days. And to hearing what everybody else has to say about this incredibly important topic. Thank you all very much.
Well, thank you very much, David. And that was an extraordinary tour de force around the status. And nothing disrupted, ladies and gentlemen, the state of health for children, women, adolescents across the world than COVID-19. And we now pass to an emerging leader in this field. Dr. Aatekah Owais is a research associate at the SickKids Center for Global Child Health. She has a PhD in epidemiology and an MPH in global epidemiology from Emory in Atlanta, Georgia. And she has led this team that undertook the assessment of direct and indirect effects of COVID-19 pandemic and response on maternal child health, nutrition, and adolescent health in South Asia in partnership with UNICEF, and looked at the impact of disruptions and school closures. And Aatekah, the floor is yours to talk to us about the impact of the COVID-19 pandemic and response in South Asia.
Thank you, Dr. Bhutta. And good morning, good afternoon, and good evening, everyone. It is indeed an honor and a pleasure to be here with you today and in the company of such esteemed panelists. I'll be presenting on behalf of our many collaborators across the globe in South Asia, some of the work that we've done over the past couple of years, looking at how the COVID-19 pandemic is affecting and in many cases upending the lives of the most vulnerable across the globe. My talk, as Dr. Bhutta mentioned, will focus on how COVID-19 has already affected and will continue to affect the health and nutrition outcomes for women, children, and adolescents in South Asia. Next slide, please. So a bit of background on South Asia. South Asia is home to more than 1.8 billion people, and about 10% of them live below the international poverty line of USD 1.9. There were more than 1.5 million deaths among children under 5 in 2018. There are 1/3 of children under the age of 5 who are stunted, and an additional 15% are wasted. And as far as reproductive health are concerned, less than 50% of pregnant women received 4 or more antenatal care visits. So given these existing challenges, the impact of COVID-19 mitigation strategies on the health and well-being of women and children is and continues to be a cause for serious concern. Next slide, please. So we know that COVID-19 has triggered a global economic crisis, which has led to the disruptions in food systems and people's livelihoods, and which in turn has led to an increase in food insecurity and households being unable to access more nutritious foods. And this crisis continues. A recent report by the FAO estimated that 193 million people in 53 countries continue to face food insecurity in 2021, which was an increase of about 40 million from the year before, or an increase of about 30% from the year prior. Per capita income in low and middle income countries has decreased by almost 8%. And this has led to an increase in the number of people living in extreme poverty and facing acute food insecurity. Countries which have a high dependency on food imports or remittance inflows are most at risk of widespread food insecurity. And within these countries, poorer households in urban slum areas were most likely to be affected, especially in the short term, due to the high number of daily wage laborers, increase of cost of food, and a lack of social support programs. As a result, childhood wasting is expected to have increased by 14% in 2020 compared to the previous year's level. Next slide, please. There are also several additional risk factors that are likely to impact maternal and child health in the region and are threatening to reverse some hard-fought gains. Disruption in essential maternal and child health services such as family planning, antenatal care, and facility births are going to result in an increased number of unintended pregnancies and adverse birth outcomes. And school closures since March of 2020 have likely led to a decrease in educational attainment, especially for girls, which will have intergenerational impact, since we know that higher maternal education is indisputably linked to improved maternal and child nutrition outcomes. Next slide, please. So this brings me to how we conceptualize the COVID-19 pandemic response could potentially impact the health and well-being of women and children. Based on experiences from the past health and economic crisis, population health and well-being can be impacted through multiple pathways, including, as I mentioned earlier, reduction in health services coverage, disruptions in food systems, but also job losses and disruptions in education. The economic crisis and school closures in tandem are likely to give rise to an increase in school dropouts, as older children may choose to leave school and enter the labor market to support their families. But this, of course, comes at a cost to their future earnings, which would have been higher if they had been able to complete their education. And as mentioned already, school closures have a gendered impact on girls, many of whom will likely get married off early and bear the higher risk of adverse birth outcomes and child health outcomes due to adolescent pregnancies. Next slide, please. So our work particularly focused on South Asia's 6 most populous countries, namely Afghanistan, Bangladesh, India, Nepal, Pakistan, and Sri Lanka. And we used actual observed changes in health services and intervention coverage to assess the impact on maternal, child, and adolescent health, as well as the impact of prolonged school closures on educational attainment of school-age children and adolescents. I also want to take this opportunity to thank our collaborators, especially the colleagues in UNICEF country offices and IFPRI New Delhi, who assisted us in collating health system information data collection. Next slide, please. So what we found is quite alarming. In the second quarter of 2020, which of course corresponded with the most stringent COVID-19 control strategies being instituted in the region, coverage of essential sexual, reproductive, maternal, neonatal, and child health services declined substantially across South Asia. And the major casualties were family planning services and treatment for infectious diseases and severe acute malnutrition. And these were the 3 services that were most critically affected. Between July and December 2020, there was a gradual recovery. However, coverage of all these essential services remained below pre-pandemic levels. In the first quarter of 2021, coverage of family planning services, treatment for pneumonia, and severe acute malnutrition among children under the age of 5 increased substantially to above pre-pandemic levels. And all the other services that we assessed had also recovered to pre-pandemic levels. However, these gains were unfortunately reversed in the second quarter of 2021, which of course coincided with the Delta variant fueled surge in India and the rest of South Asia in April and May of last year. Next slide, please. Educational attainment has been another casualty of the pandemic. There are approximately 420 million school-age children in the region, and many of them were out of school for a prolonged period of time since March 2020. South Asia has had the longest school closures than any other region in the world, with the mean duration of school closure standing at about 64 weeks by October of 2021. Although all the South Asian countries had instituted policies for remote learning relatively early in the pandemic, a report published by UNICEF found that one in 3 children in the region could not be reached by any form of remote learning, with the proportion being much higher in rural areas and poorer households. And this is, of course, the best case scenario. The actual number of children who had no or very little schooling during these school closures is likely much higher. School closures can lead to loss in educational attainment in multiple ways, such as loss in learning time, loss of already acquired learning, as well as the increase in children who drop out of school prematurely. And this last is what our model on loss in educational attainment focused on. Next slide, please. So based on our model, approximately 9.5 million children are likely to have dropped out of school prematurely in South Asia as a result of the prolonged school closures, with more than 6 million of these children being middle school aged. We estimate that this will also lead to an increase in inequity in educational attainment, since more than 40% of children dropping out are estimated to be from the poorest households. This reduction in educational attainment will, of course, have an impact on these children's future earnings, and their lifetime earnings are likely to decrease by 20% on average. Next slide, please. And of course, as I already mentioned, there is going to be a gendered impact on girls. Of the almost 10 million children expected to drop out of school due to COVID-19 related school closures, half of them will be girls, many of whom will be married off, resulting in an increase in the number of early or adolescent pregnancies. This early start in childbearing is likely to result in up to 450,000 adolescent pregnancies in South Asia for this cohort of girls. And this will also lead to an increase in the number of adverse birth and child health outcomes. We estimate that an additional 700 to 800 maternal deaths and between 13,000 to 14,000 more neonatal deaths could occur as a result of the increase in early marriage and adolescent pregnancies. There will also be an increase in low birth weight births, and as a result, almost 30,000 more children will be stunted by the second year of life. There are, of course, regional differences in the burden borne by the countries in South Asia, with the highest burden expected for India and Bangladesh. Next slide, please. So what is it that we can do to not only minimize the effect of the ongoing pandemic, but to also ensure that we are prepared for the next one? First and foremost, there is a desperate need to reestablish and continue to provide essential health services to the most vulnerable populations. And we can do that in multiple ways. For example, using telemedicine, strengthening infection prevention and control in health centers, and make sure that the supply chain and the delivery of essential commodities, such as family planning services, is protected. One thing we have also learned from the COVID-19 pandemic is the need to keep schools open. And we can do it and continue to keep schools open by making them safer for children. Some of the ways we can do that is to perhaps put limits on class sizes, alternate school days, ensure that mask mandates and temperature checks are carried out, and of course, ensure reliable and safe transportation to and from schools for these children. And last but not least, there should be an increased focus on social safety net programs for the most vulnerable populations, including children and adolescents. And with this, I thank you for your attention and look forward to an engaging discussion. Thank you very much.
Thank you very much, Aatekah. And we will move straight on in the interest of time. And it gives me great pleasure to invite our next speaker, who's none other than Professor Ezeh, who is the Dornsife Professor of Global Health at the Dornsife School of Public Health at Drexel University in Philadelphia. Alex was a founding executive director of the African Population Health and Research Center, APHRC, and guided it to become the Africa's foremost regional research centers. His work focuses on urban health, population change, and models to strengthen knowledge-based institutions. And he also co-chairs currently the Lancet Commission for Adolescent Health and Wellbeing. And he'll speak to us today about Sub-Saharan Africa and what's the future of adolescent health and well-being? Take it away, Alex.
Thank you, Zulfi, and thank you for the invitation to be part of this panel. I have been asked to speak about Sub-Saharan Africa and particularly issues relating to sexual and reproductive health and rights within the region. I will start from Sub-Saharan Africa, but as Zulfi indicated, I currently co-chair the Lancet Commission on Adolescent Health and Wellbeing. And I'm acutely aware that the challenges young people face today are quite complex and multi-faceted in many ways. And they do require collective action and urgent action as well. So while drawing from experiences in Sub-Saharan Africa, a lot of the things I have to say and speak to will apply to youth globally. So can we go to the next slide, please? If you look at Sub-Saharan Africa in 1950, that's about 72 years ago, adolescents aged 10 to 19 accounted for about 7.8% of the total global population of adolescents 10 to 19. If you added North Africa, that will give you another 2% on those. Together, Africa as a whole accounted for about 9.8% of the global population. That's less than 10% of the world population. Today, Sub-Saharan Africa alone accounts for 21% of adolescents 10 to 19. If you include North Africa at another 3.7%, that accounts for about 25% of the global population. That is, 1 in 4 young people today in the world aged 10 to 19 lives in Sub-Saharan, in Africa. Over the remainder of this century, this proportion will increase significantly, with Sub-Saharan Africa alone accounting for 43% of the global population of adolescents. And if you include North Africa, that will give you about half of the population. That is, by 2100, 1 in 2 young people aged 10 to 19 will be living in Sub-Saharan Africa, in Africa. This situation is as pronounced when you look at school-age children, and they have huge implications in terms of the ability and capacity of countries and governments to make the necessary investments, whether it's in health, in education, and all the other things that's needed to really support the development and growth of these children. More than ever before, the place where adolescents grow up have a huge effect on their life chances as well as their future. Therefore, this spatial shift in terms of where adolescents are located, if it is not accompanied by significant shifts in the well-being of adolescents in Sub-Saharan Africa, will lead to an overall worsening of the health and well-being indicators of adolescents globally. Unless we can make significant shifts and changes and improvements in the health and well-being of adolescents in Africa, it's everything we do at the global scene is likely to not see significant improvements in the well-being of adolescents globally. I'll go to the next slide, please. So what is the situation currently of adolescents in Sub-Saharan Africa? And in terms of health, well-being indicators and sexual and reproductive health, you can look at many different areas. But first, if you look at adolescents, you can think about schooling outcomes. And currently, about 17% of adolescents globally are out of school. In Sub-Saharan Africa, that's about double that average, with almost about 35% of adolescents in Sub-Saharan Africa are out of school. At the global scene, we have about 59 million children out of school, and about 60% of them are located in Sub-Saharan Africa alone. We can think about labor participation, and you can look at adolescents in Sub-Saharan Africa, and they look like they are doing well, better than the global average in terms of the number of them that are in employment, or the proportion that are not unemployed. However, this actually masks the fact that 95% of adolescents in Sub-Saharan Africa do work that is not remunerated. That is, they are neither salaried nor earn wages from that employment. For adolescent girls, one of the most common options available to them then is to get into marriage. And on average, females in Sub-Saharan Africa marry at about 3 years younger than those elsewhere compared to the global average. More importantly, childbearing actually begins much earlier in Sub-Saharan Africa. And if you look at the rates of childbearing there, it's about 2.5 times the global average. And this global average does include Sub-Saharan Africa as well. So in Sub-Saharan Africa, we're looking at adolescent birth rates of close to 96 per 1,000 adolescents compared to a global average in around 35 at this point. So without changing early marriage that we see on the continent today, it does seem to me that it will be difficult to address most of the challenges that adolescents in the region face. The issue of early marriage is something that we've not paid as much attention as we should, because it has huge implications with both the growth of the population and the health outcomes of adolescents generally. Can we look at the next slide, please? So what are the implications of these factors with respect to adolescents in the region? You can look at pregnancy-related deaths in Sub-Saharan Africa. It's currently, for a 15-year-old girl in Sub-Saharan Africa, the risk of dying from a pregnancy-related death is about 5 times higher than the global average. And this has a multi-layered implications for the future and well-being of adolescent girls in the region. If you think about HIV risks, 6 out of 7 HIV infections, new HIV infections in adolescents in Sub-Saharan Africa today occur among girls 15 to 19. As I noted earlier at the beginning, these might be unique health and reproductive health concerns of adolescents in Sub-Saharan Africa. But there are also multiple threats that adolescents globally face. And in the work we are beginning to do now within the Lancet Commission on Adolescent Health and Wellbeing, I would like to just highlight some of these issues, which are actually very pertinent to the conversations that we are having here today. Next slide, please. So adolescents face multiple challenges, irrespective of where they live globally. While the demographic shifts will result in adolescents in Sub-Saharan Africa having much larger proportions of them, and with implications it might have in terms of opportunities that will be there, it does not mean that the shifts are not affecting adolescents in other regions. If you think about places outside of Sub-Saharan Africa and most parts of the region, both the total number and the proportions of adolescents in these populations will be declining. David had noted this as well, because of continuing low levels of fertility and high life expectancy at birth. This will have implications, most of which we have not even at this point begun to think about. Inequalities is one of the things that's really galvanizing a lot of action from the perspective of adolescents. It's also one of the threats that we face in our current civilization, the fact that inequality is growing both within countries and across countries and regions of the world. So when you look at this, young people in some ways are acutely aware of the ways that many adults are not able to understand in terms of the way they think and feel and think about inequalities. It has been one of the rallying points for many of the youth-led social movements in the past decade, from climate action to the Black Lives Matter movement. Young people see a world in which their future is compromised in multiple ways. and growing inequality exacerbates these concerns and risks. This particular Global Perspectives panel is about navigating transitions. We have lived in periods where we had predictable pathways of transitions from adolescent to adult roles, and that particular era is quickly disappearing. Regular jobs following college graduation is often rarer. Marriage and parenthood are occurring much later, and the changing nature of work is blurring the distinction between personal life and work life. Unfortunately, many of us as adult parents do not see or not understand these transitions and the changing pattern of transitions and the way they are occurring, and maybe frustrated and putting pressures on our own adolescents in terms of our expectations on these traditional pathways of transitions when they are not happening in our own circumstances. So we need to look through this and think about the pathways of transition and what it means in different settings for adolescents. Dr. Owais has spoken about COVID pandemics, and I will not dwell on that. But the key point here is to recognize that every single challenge that we face currently at the global scene has been exacerbated in many different ways by COVID-19. It has resulted in unprecedented interruptions in education and extreme social isolation for young people everywhere. The implications this has for mental health is currently being felt but poorly understood. And I think this is an opportunity to begin to think about this. And maybe one of the ways to begin this process is to start by listening to young people who are experiencing these issues in ways that no other generation is. And by bringing them and listening to them and hearing their own perspectives, I think we might begin to understand how best we can take the type of action that is needed to mitigate the challenges that they face, and again, the triple dividend that David spoke to earlier. Thank you, Zulfi.
Thanks very much, Alex, for that really powerful presentation. Now we have under 20 minutes, so we will try and get to some questions and some points that have been raised in chat. And I'd like the panel to answer these as succinctly as possible because we'd like to get 2 rounds in. So I want to start with you, David. And as the architect of the AHA framework for WHO, which is the first time we looked at this, we've particularly been keen on targeting young adolescents in terms of getting the maximum impact of interventions if you start early. So I'd like you to say what, in your view, is the optimal strategy for integrating school-age health and education interventions and make that a continuum into young adolescents at least?
Yeah, so I think that one of the lessons that we've really learned over the last 20, 30 years in global public health as a whole is the importance of thinking across the life course and not siloing ourselves into thinking only about one particular age group. So a lot of the problems that adolescents face start earlier in their lives. And similarly, a lot of problems that adults or older people face start in adolescence or before that. And so I think that schools and educational institutions as a whole are an incredible resource for trying to shift the whole perspective, the whole situation of global health. It's one of the few times when everybody is in a place, or almost everybody is in a particular place in the life course. After that, people split off to hundreds and hundreds of different jobs or lack of jobs, thousands and millions of homes. But when they're in the schools and their educational institutions, this is a time when one can really reach them with messages, but also with changing attitudes towards the future. And So I think that the links between, if you like, school health and adolescent health have to be extremely strong. And the Global AHA is really pushing that. It's linked to work which is going on across WHO, UNICEF, and others related to trying to make every school a health promoting school. And there's documents that have been issued just within the past year to support that initiative. And also to just mention that coming up next year, the plan is that there will be a very large and active global forum for adolescents that will happen in September, October next year. It'll be a virtual forum and will be linked to the SDG Review Summit that's happening next year and the UNGA. And we really need to build towards that to make sure that we make full use of it.
Thank you. Thank you, David. I'll come back to you on the important issue of, how do we make these linkages work? But also importantly, how do we make sure that these are done in a manner that also engages policymakers? It's great to give adolescents voice, but how do you influence people who own the checkbooks? Let me turn to you, Aatekah. You made a very compelling case for what's happened with COVID-19 in South Asia and across the range of health and nutrition and particularly birth outcomes. Dr. Ram Prakash from Public Health Foundation of India, not very surprisingly, has raised a very important point, which is how much do we know about the mental health consequences? And what can you say about what your scholarship has indicated, at least for South Asia?
Thank you. Yes, although we didn't focus on mental health specifically, there is plenty of emerging evidence that suggests that the school closures have led to a deterioration in mental health for adolescent and school-age children. Notwithstanding, as Dr. Ross just mentioned, the social isolation that these children were in for months at a time during the prolonged school closures, but also because their households were affected negatively due to the economic impact of the COVID-19, leading to increase in domestic violence, again, for girls, leading to early marriages, potentially against and probably against their will, so to speak. So there is no doubt that there has been a tremendous impact on the mental health of adolescents in South Asia, as well as across the globe. Unfortunately, mental health is not well studied in that region. So we know very little about the epidemiology and the burden of the disorders that are most prevalent in South Asia. So that is definitely an area of research that should be focused on. Thank you.
Thanks. Alex, compelling case for particularly the case of adolescent health in Africa. Well, let me ask you, how much do we know, not only about the burden, status, distribution, inequities, but also on what can be done in conflict settings and humanitarian considerations? For many people believe that adolescents in those circumstances are the most marginalized and have the least agency. So give us a sense that there is something that can be done in that setting, and what can the humanitarian agencies do in particular to bring adolescents into the equation?
Thanks, Zulfi. In terms of humanitarian settings, I think if you look at the globe today, some of the things that's really affecting young people and the concerns they have are quite many. We talked about the issues in what David presented in terms of violence and interpersonal violence and road injuries and all of those. These are clearly issues and concerns that young people face and contributes to the mental health situation that we are talking about. But in conflict situations, we've seen the implications of that with movement, and young people are more at risk within those. In terms of what can be done, I think it's the issue is at this point is to recognize that these conflicts are there and are growing in many different settings and will be exacerbated in other ways. In many parts of Nigeria, you look at the situation is really hopeless in some ways with respect to conflict, and young people are affected. You then focus more of in the larger conflict settings where there are wars, like what's going on in Ukraine or in Syria, in different other places where there are states are not able to cope with this situation. The situation of adolescents within those need attention. But the work we've done actually, Zulfiqar, like the work we did in Nairobi suggested that if you look at the indicators that we use to determine emergencies, and you look at them within slum settings in different parts of Africa, children growing up in those settings, actually living in those emergencies, their experiences are often worse than the baseline we use to define those emergencies. So we need to recognize that. And that's really a new phase of challenge that is staying with us. When a 9-year-old in the slum is telling you that their number one concern is being knocked down by a vehicle going to school in the morning, it raises questions. When a child in the school in the US is telling you their number one concern is being shot at school, or conflict at home as issues that they are concerned about. These are not regular things we think about when we think about mental health concerns of young people.
But on a positive, of course, is highlighting the issue that has been currently ignored insofar as urban slums are concerned, particularly large mega cities with those populations. But I think, Alex, there is a great opportunity of bringing some of these issues into the guidelines and processes that many humanitarian agencies use, the responses that we have, which have until very recently only had a limited repertoire of what needs to be done for reproductive health. David, I'm going to put you on the spot because, the thing is with school age, children and adolescents, the common denominator there is schools. But we know the millions that are out of school. So is there anything in the global framework for children who are out of school, who drop out? I mean, what do we do in terms of reaching those? And are there innovations that one can bring in from the maternal child health field of community strategies that can at least reach them?
Yeah, well, I think that one area that has not been exploited enough is clearly the digital areas, where I'm not only thinking about the internet, which obviously is incredibly important, but there are many of the least advantaged people have less access to it than the more advantaged people. But also just the things that can be done through a dumb phone or a smartphone. I think we need to really look at what is possible there. And to be honest, the research is still pretty weak in this area in terms of really establishing the effectiveness of programs. But I think there's some lots of good innovations that are coming up, in particular from low and middle income countries, in terms of what can be done, but it must go beyond just the easy stuff that you can do through digital work, which is to just provide some information, to getting to being interactive and engaging, to actually get young people to want to engage and get the messages and to interact with it. And then another area for out of school youth, I think, is that we have to think about where they are and we have to go to where they are. And often that's just not done. People as health workers, most health workers want to sit in their clinic and wait for people to come to them. And we learnt in primary healthcare, in the early days of primary healthcare back in the 1980s, that at least to start with preventive type of interventions, much of which is that's what we need in adolescence, is we have to go to them where they are, and we have to deliver our services and our preventive interventions and our information where they are, be that on the digital space, as I just said, but also where are they hanging around? Go to them there.
Community platforms and the like, and make a plug for a whole spiel of reviews on what can be done for children and adolescents that has emerged in a full supplement of pediatrics 3-4 days ago, supported by Idrc. So there is now the global evidence base around this. So we've been very generously allowed a couple more minutes by the organizers. So I'm going to play speed chess with Aatekah and Alex and give you a question to give a speedy response to. So Aatekah is a young mother, and as somebody who has actually studied this now, what could we have done differently? And that should be a lesson for the next pandemic.
3 words: keep schools open. Schools and daycare, keep them open. Similarly, keep health services open, preventive health services, especially for, as you said, young women and young mothers.
Thank you. I mean, that really captures it all. I think the evidence base around school closures was, as many of us now have been crying hoarse for almost 2 years, very weak, and in hindsight was something that we should not have done. Alex, I'm going to come to you, my friend, and ask you for a difficult question, given particularly your position now in North America as a leading academic in adolescent health. We find that the divisions across sexual reproductive health, education, empowerment are pretty rife. And now as we approach the continuum from school age to young adolescents to traditional 15 to 19 or 24 years olds, what are your thoughts on how we can get some consensus around how to approach this as parents and policymakers?
Thanks, Zulfi. First is to go with the evidence and the data and not politicize adolescent health. I think if we take politics out of it and take what we think and what our religion and culture and all of those say about this and look at what is there and what is the evidence. And I think it's not difficult to really get to a consensus. The difficulty is that we are creating the evidence to suit our position and not really looking at them for what they are. So if we actually look at the evidence in terms of objectively look at them, it's not difficult to find common grounds to address adolescent sexual and reproductive health issues, whether it's in North America or in Africa.
Well, thank you so much. This has been such a fantastic panel and a huge learning opportunity. I'd like to take the opportunity to thank the organizers, the Gairdner Foundation, Idrc, and most importantly, our phenomenal speakers who have set the scene for what promises to be a fascinating rest of the seminar. Thank you very much for your attention.